Our next speaker is Congressman Joe Courtney. Congressman Courtney has represented the 2nd District of Connecticut since 2006 and currently serves on the House Armed Services Committee as well as the Education and Labor Committee. Courtney has been instrumental in promoting NAHU's legislative priorities. The congressman co-sponsored the bill that fully repealed the Cadillac tax back in 2019. The congressman is sitting with NAHU member Justin Lubenow, who sits on the Medicare Advisory Group and serves as our agent liaison to CMS.
All right. Thank you, Congressman Courtney, for joining us today to talk about observation status and providing us with an update on this important issue for many of our members who advise people with Medicare. Many of our viewers will recall that Congressman was one of our champions to repeal the Cadillac tax at the end of 2019. And I am Justin Lubenow, the Vice Chair of the Medicare Advisory Group and the Agent Liaison with CMS. Welcome, Congressman.
Great. Good to see you, Justin. I appreciate the invitation.
Absolutely. We're looking forward to it. So before we've got certainly a list of questions we want to go through with you, I just want to set a little bit of background on the issue for observation status for some of our viewers out there and the impact it has on a Medicare beneficiary. And essentially, when a Medicare beneficiary goes in the hospital, there's this status that they get put into by the hospital, observation, until they're actually formally admitted into the hospital. And the impact on a Medicare beneficiary of this observation status versus admitted status has to do with their medical out-of-pocket costs, with whether something's covered under Medicare Part A or Part B. It could impact their prescription drug costs, whether they be covered under Part A of Medicare if you're admitted to the hospital versus Part D as in drugs if you're not admitted. And the other big impact has to do with skilled nursing care and the out-of-pocket costs it could have on a Medicare beneficiary if they happen to go into skilled nursing and they're not actually admitted in the hospital. So those are some of the main themes. We're going to get into some specific questions, but I just want to kind of level set the foundation of this observation issue for some of our viewers out there. And the first question we have, last year, despite broad coalition support and bipartisan congregational support for addressing this ongoing problem for seniors who need this skilled nursing care, we could not get this bill across the finish line. And the question is, what do you think is different with our chances this year?
Sure. Well, thank you. And nice job sort of doing the nutshell description of it, because it is kind of tricky and but extremely important to patients because, at the end of the day, if there's a coding issue, between a hospital and Medicare, let them fight it out, but the patient should not really bear the brunt. And I was with some groups here where we called it the mother of all surprise billing. When someone finds out that, some code entry suddenly just, triggers this incredible out-of-pocket, particularly with skilled nursing facilities. So, actually the effort to fix this goes back actually a number of Congresses. So it wasn't just the last one where we sort of stalled out last year, but, this is a bipartisan issue. I mean, if you look at the efforts over the last 3 or 4 Congresses, we've actually had a really impressive mixture of Republicans and Democrats because, again, it's a national problem. It hits every district, red or blue, and it's an issue which I think COVID really did, in my opinion, in the last Congress, become the sort of speed bump that we couldn't get over, but it's not, frankly, all sort of gloom and doom. I mean, what happened during COVID actually may give us new arguments about why a fix really makes sense for the system. And so we're going to restart the process soon. We've already obviously been talking to NAHU as well as other stakeholders, a lot of senior elderly advocacy groups, a lot of healthcare providers, social workers who get the sort of nasty job of having to explain this to families, when they run into this black hole. So we think we've actually got some new, fresh material to take to my colleagues. And again, your organization's support means the world. I mean, again, when you look at sort of an issue like Medicare, it's not something that normally jumps out that a group like NAHU, who has lots of different kinds of clients, would jump in, and you have a lot of credibility, and you can make a difference.
I appreciate that. And you mentioned Medicare and NAHU. I mean, it's definitely a growing area within NAHU. And, our goal is really looking at it from the beneficiary's perspective to try and improve the system, improve the process. So anything we can do to help that, for sure. And it's interesting. You mentioned, the pandemic, right? And the impacts it's obviously had on priorities in Congress. The other thing that the impact was, with the that 3-day stay requirement, was waived for the skilled nursing coverage under this situation due to the pandemic. And, I'm curious, how does that change or affect, a legislative remedy for this issue?
Well, number one, again, just going back to the last Congress, I mean, to be honest, it actually took a little bit of the urgency out of the issue, because as you point out, there was a waiver put into place, and there was kind of a bubble or safe harbor where, this really nasty problem for patients suddenly, became less, urgent. And, but having said that, I mean, it also gives us, I think, some data and some, a snapshot of whether or not, having some of these restrictions in terms of continuing Medicare coverage for medically necessary care, maybe are not as important for the fiscal health of Medicare, which is, let's face it, I mean, that's sort of the fundamental objection that we run into in terms of either, getting rid of the 3-day stay or allowing, the patient to avoid the impact of the 3-day stay in terms of, the way the codes get written. And, we've had, numerous attempts over the years, which run into resistance at Medicare, with the Department of Health and Human Services, as well as the Congressional Budget Office, who sort of see this as just sort of opening the floodgates. And so, again, with the benefit of hindsight in 2020, I mean, we can actually maybe really get some real data as opposed to just kind of, sort of fear, that might sort of drive sort of political opposition to it.
So one of the things we've heard about this issue, and some of the, I guess, the pushback we've heard is potentially from, hospital associations and things, that there's this, this readmittance situation where if they do put someone into an admitted status versus observation, and then they're readmitted to the hospital within a certain period of time, their reimbursements are impacted from Medicare, and obviously they're trying to protect their bottom line. And so, that's one of the hesitancies with putting someone from an observation status into an admitted status within the hospital. I'm just curious, is there any thoughts on that? Is that, are you seeing any of that pushback from any of the hospital associations, or any feedback on that topic?
I mean, to be honest, I mean, our sort of take is that they've usually taken a kind of a neutral position on this bill. And, the readmittance rules, which were part of the Affordable Care Act, sort of post-dated this issue. I mean, in other words, the rise of Part B coding and observation status really predated the readmittance rules. So that one we're not really, sweating out as much. I guess I would leave it at that.
Okay, understood. Yeah. Now we've heard some new data out there that shows low income and disadvantaged people are being denied the skilled nursing benefits and cycling through multiple hospital stays in disproportionate numbers. Yet those who get skilled nursing care don't, have that same issue. Does this data provide any new sort of leverage for the current administration, and as far as pushing this issue through and getting it resolved because of the disproportionate impact that's out there?
Yeah. So, when we talk about sort of fresh new arguments, this study, which came out of Minnesota, Dr. Sheedy conducted it, really top-notch person, really, very thorough and data-driven, basically described what you just stated, which is that, where this lands in terms of what patients really, take the biggest hit when they're put in observation status, does track, lower income, socioeconomic status, and patients of color. And, when you think about it, it's maybe, some people may say, well, why is that? But the fact is that, patients who maybe come from different levels of socioeconomic status, maybe are a little bit more cognizant of this issue and maybe a little more vocal, and are just able to sort of fend for themselves a little bit in terms of the complexity of the hospital system. And that's certainly not the case otherwise. But the one thing is she shows that this problem is not sort of neutral in terms of impact on different populations in the country. And I think that that data is really, I think, going to be very helpful in terms of the argument that we need to make. She also, I think, demonstrated, as you point out, that these discharges where people, again, are sort of stranded in terms of Medicare coverage result in readmission to a much greater degree. And frankly, from the fiscal, health policy standpoint, that's just a completely unacceptable situation. But frankly, it also helps us make the argument that doing nothing actually costs as much, if not more money, in terms of hospital readmissions and emergency departments, because those are the highest reimbursement rates Medicare pays as opposed to other forms of care.
Yeah, no, that's a good point. I mean, I think part of the study showed that the folks that are getting the skilled nursing care, to your point, are not coming back to the hospital, right? They don't need the additional care because of the skilled nursing care. So that to your point, that gives you some more leverage. The other thing you mentioned there, Medicare is a complicated thing, right? For us, we do it it's not for us because we do it every day, but for a Medicare beneficiary, it's a complicated system. And then you pile on top of that someone who's in the hospital, right? And there's this stress, there's something obviously going on if you're in the hospital. And on top of that, for someone to have to understand the difference between, these statuses, these diagnosis codes, it's just, it's frustrating, for the beneficiary, and then you add on top of that, to your point, we're looking at a lower income or disadvantaged people that maybe don't have the same whether it's communication or level of education about this issue, and they just get double whammied in this situation. They don't get the skilled care that they need. So I hope that helps provide you some leverage to.
No, we were very excited about that study when we learned about it.
Great. I want to circle back on that, the 3-day hospital stay rule, and just trying to get an understanding is, we know that it was waived, that 3-day stay is waived during the pandemic. Our understanding is it's still underneath that I guess waiver situation. Is there, to your understanding, any sort of end to that waiver period or schedule end as far as when that might,
right.
end? Yeah.
Well, again, if you really do the forensics on it, I mean, the 3-day stay or 3-day requirement really goes back to the dawn of Medicare. And as we all know, healthcare looks a lot different these days, and so the sort of shift to more outpatient, day surgery, all that sort of trend that didn't exist, back in 1965 and 70s, et cetera, in some ways, is the reason why really that 3-day rule should be looked at. And again, so in 1989, the Medicare Catastrophic Act was passed by Congress, which actually got rid of the 3-day rule. And it was a bill that was very controversial, huge backlash because there were some higher out-of-pocket expenses without going through all the chapter and verses of it. But in any case, it was repealed within about a year of enactment. And there was some evidence back then that that it was getting rid of that 3-day rule was going to spike up more admissions and more utilization in different other parts of the system that was there. And that's something that frankly is kind of a hangover with the Congressional Budget Office, that whole experience, back in 1989. I was in the state legislature at the time. I actually remember that whole sort of exercise that took place there. But as I said, healthcare looks a lot different now. There's just better ways than sort of watching the clock, in terms of discharging a patient, because that's wasteful or can be wasteful in and of itself. And depending on how the study that we discussed is sort of received, whether or not we can sort of make some more headway with CBO. I mean, I mean, look, I know Medicare Advantage plans don't have any 3-day requirement, or some of them don't. So there's now it's a much more it's a different landscape in terms of how this issue is being handled than it was back in the 1980s and 1970s. So better than anyone, healthcare is very dynamic. Yep. And sometimes the reimbursement systems and the coverage systems take a while to catch up to that change.
Yeah, absolutely. And you mentioned you think about the financial stability of Medicare, right? And we read these Medicare trustees reports, and every year they come out and it gets dire, more dire each year, right? As far as when that hospital fund is going to run out of money. I think last year was 2024. With everything with COVID now, I don't know what this year's report is going to show. It's probably going to be pretty scary as far as when that fund is, going to run out of money. And to add on, to your point, if this issue gets resolved based upon the data point you have from 1989 and the cost implications on Medicare, probably the Part A fund, that's I guess are there any discussions going on about this big looming this Part A hospital fund? And just to digress a little bit, but it's kind of related to this issue.
No, absolutely. Yeah, and I mean, I think that there frankly was not much work being done in the last few years in terms of really paying attention to this. And I think looking forward to the next Congress, particularly the area of prescription drug costs, which is definitely one of the big cost drivers in terms of Medicare's financial I don't want to say instability, I guess is the right word. That I think that you're going to see that issue, and if you run the numbers in terms of some of the proposals that are out there, I mean you can accumulate massive savings for the Medicare program, which every time you do that, obviously it pushes out that solvency year that's there. But no, this is I mean, Social Security is one that people talk a lot about, solvency of the system, but as you point out, Medicare, the blinking red lights are flashing, right now, and it's gonna force itself, to be dealt with if we don't get our arms around it sooner rather than later.
Right. Okay. So I guess from a NAHU perspective and our members' perspective, when we think about this, this observation issue, we think about how can we help? What's the way we can have the biggest impact on getting this resolved and providing a better beneficiary experience? At the end of the day, that's, I know we're an agent organization, but our association is about helping the beneficiary when it comes to Medicare. And what can we do? I mean, we bring stories to our local Congress people about people that were impacted, and I'm curious, what are your other thoughts on how we can help?
Well, certainly, bringing the stories is still super important. Personalizing an issue is just always, the most effective way to connect, I think, with representatives. And as we know, these personal stories are pretty gut-wrenching at times with, some 80-year-old who, broke their hip and, gets discharged and coded the wrong way and finds themselves, as I said, completely in limbo as far as getting care and financially the threat. So, still got to keep that on. By the way, I mean, we obviously have a whole host of new members in the House of Representatives. So there's, and this is an issue which it's been pretty well reported on over the years, but it's sort of intermittent. It's not something that, probably even the average new member is really going to be that familiar with necessarily. So, that Hill contact is still really important. As I said, you guys are a highly credible voice, and would certainly encourage, that activity, which is never ending, to sort of keep doing. And I also think that, that discussion doesn't necessarily just have to be between your members and a congressperson. It also can happen in the public. You know what I mean? Because getting the public discussion, public awareness, in whatever kinds of forms that you can sort of possibly think of. I mean, that's really, that's what kind of creates the environment for legislative change. And so, as I said, you're dealing directly with patients and people, and you're obviously folks that get issues of, financing and cost. I mean, as I said, I think you can do a lot.
That's helpful. We'll continue to, whether it's social media or other ways of getting this issue out there. I think the challenge, with something this is a very complicated issue, right? I mean,
Right.
it's you really have to understand health insurance, Medicare, Part A and B, and different parts, and kind of the impact it has on the beneficiary. And so I think it's on us to continue to educate. And like you said, with all the new Congress people that we're going to be meeting and, going through and just providing that foundational education and continuing to do that. So we will continue to do that. So, but that's essentially the key topics that we wanted to cover today. And again, we certainly want to thank you, Congressman Courtney, for taking the time and again for your continued support on this observation issue. And we really look forward to driving this thing over the finish line. This is from a Medicare advisory group perspective, this is one of our top two. Our other big issue is that COBRA issue. I've been working on for quite some time as well, and we're looking forward to getting these both over the line. Hopefully, with this this current administration, in the next short little while here. So thank you again, and really appreciate your support. So.
Great, thank you, Justin. Remember, sometimes this takes a while to get through the legislative process. We just went through it with the Cadillac tax, and that took 10 years. And hopefully, we can shorten that time span for an issue like this. But again, you got a great team in Washington, and you've got some good members in Connecticut, where I hail from, and we look forward to working together.
Great, thanks again.